I'm very happy to be with you this month again to our monthly appointments. And please be free to comment throughout the webinar. It's a live discussion, actually, and I want to share with you experiences and cases that you might confront in your everyday practice. And we're going to talk a bit about gastric hemorrhage and ulceration, which is a very, very common cause of admittance of a lot of our cases in the clinics. Of course, we have gastric erosions, where the hemorrhage and the ulceration is not that deep. It's superficial for more shallow areas of mucosal disruption. And we have gastric ulcers when we have a deeper disruption of the mucosa. Sometimes we can have a raised thickened border, and the ulcer can look like a crater, actually, a volcano crater. And sometimes we might have also yellow or necrotic tissue, and we can differentiate between inflammatory ulcers and neoplastic ulcers, but not microscopically. This is very difficult. Of course, we always, when you're an experienced endoscopist, you always have a first, gut feeling if this is neoplastic or not. And you might also combine with the clinical history of the animal that's admitted, but most of the times your biopsy will give you the results. And having said that, a good biopsy will give you the results, because you might have a very nasty adenocarcinoma, for example, or an adenocarcinoma in the very early stages, and your biopsies could be from the necrotic center, for example. So there you will only see necrotic tissue and not neoplastic tissue. So you will have a false diagnosis. So the neoplastic ulcers, most of the times, are single. They're located in the incisura angularis, and they have a crater form. The ulcers from uremia, and of course here there's a big question mark, and I will explain why, or diffuse or gastritis are mostly diffuse. It could be patchy, in the pyloric region or in the fundus in the body of the stomach, because we're talking about a more diffuse disease. And ulcers from non-steroidals are mostly located in the antrum. There are multiple dots in the antrum. And there could be a variation in the ulcers from non-steroidals. We could have ulcers that are deeper, depends on the dosage that the animal has consumed, and also upon the chronicity of the administration, the duration of administration. So I will present to you a case, which is this case. I'm not going to show you now the endoscopic procedure. I'm going to show it to you when we're presenting the case. And this is an ulceration this is the pylorus, and this is the antrum. And these are the ulcers from one single dosage of meloxicam, which is considered actually very innocent as a non-steroidal as well. And this is a picture of supposedly uremic gastritis, but we will comment on that. The biopsies should always be from the periphery of the ulcer and not from the necrotic center, as I told you, in order to have more diagnostic samples. Let's go to the next one. Okay, here's a video of dotted ulcerations in the antrum, because this dog had spinal cord herniation, and they started off with non-steroidals, which did not work very well. The animal was not responsive to non-steroidals. And then, without a gap between these two medications, they tried corticosteroids. So these are dotted ulcers after 1 week of corticosteroids administration. Then the dog started vomiting hematemesis. As you see, the ulcers are not that small dotted ulcers in the antrum area. They're not that deep. Yet, if we would continue on the administration without considering that it could be due to the combination of the medications, because for glucocorticosteroids, it's not proven, it's not evidence-based that they can cause primarily the ulcers, but for the non-steroidals, it's a de facto situation. Which are the risk factors for ulceration? Ulcerogenic drugs like non-steroidals, and we have a huge list of ulcerogenic drugs here. I'm not going to go through that. Mostly it's non-steroidals, and hypovolemic shock, because the gastric mucosa is not the blood flow is very reduced in the gastric mucosa. In extreme exercise, we have a lot of references about gastritis and gastric ulcers in working dogs and in huskies, for example, with sled that do the sled work. So these animals are very prone to gastric ulceration. Now, let's go to define a bit more about the uremic ulceration. Is it a myth or is it a reality? Do we really have gastric ulceration out of kidney disease, chronic kidney disease? So there was this in 2017, there was this in Journal of Veterinary Internal Medicine. There was this report. Of course, a lot of more reports should follow this result. And they evaluated the gastric pH in cats with chronic kidney disease and the gastric pH in normal cats. And to date, no evidence of chronic kidney disease causing gastric ulcerations due to hyperacidity could be defined. So these animals do not need acid suppressant. And as you may see, a lot of other cases will not need acid suppressants. Were there any limitation in this study? Yes, because the sample size was very small. So we need more studies upon that. And no evaluation for the gastroduodenal mucosal bleeding was made, but this was a start. This was a start in order not to assume or take for granted that uremic disease patients might develop gastric ulcerations. Okay, let's go to this first case of gastric ulceration. This was a very recent case of a Shar-Pei that was admitted to our clinic. As you may see, the dog, she's 9 years old, she's spayed, and she has lost some weight. So she has been vomiting 1 month priorly admission. It was mostly food and gastric fluids, and the frequency was 3 to 4 times per day. But only the last 10 days, this progressed to hematemesis and melena. So the owners have not noticed anything about hematemesis or black feces during the prior period. She had a very poor response to common antiemetic treatment, like she was, for example, administered maropitant, ranitidine, metoclopramide, hypoallergenic diet, and she was also on gastrointestinal diet, but with no response. And she experienced weight loss, anorexia, and depression, up to the point that she was very reluctant to move and to go out for walks. The physical examination findings, very pale mucous membranes. This dog was very, very profoundly anemic when was admitted to the clinic, a weak threaded pulse. When we tried to palpate the cranial abdomen, she exhibited signs of pain. Actually, she went to bite us, to snap at the doctor. Hypersalivation, fever. Of course, always do not forget to do a rectal examination because it might save you. not in this case that the owners actually perceived that the dog had very dark feces, but in other cases, it could be the case that the owners do not understand that the dog might have melena, for example. So it's very, very prudent for you to do a rectal examination. So of course we had dark and tarry appearance in the feces, tachycardia, probably due to anemia as well as a response, and the body condition score was 2 out of 5. Whenever you want to have a diagnosis, always create a differential problem list. And I have it in all the cases. These are cases that we have also, for those of you who haven't had the chance to watch them, we have uploaded these cases in Aohua YouTube channel for everyone to have access to these cases. And we're going step by step in the diagnosis. So the problem list in this patient was that it had chronic vomiting and during the last days, hematemesis, melena, anorexia, and fever. What are the causes of canine gastrointestinal ulceration? We're not going to go in depth into these. Of course, drugs, metabolic diseases, and like Addison's disease. Please try to exclude Addison's, not only on a geriatric patient, but only on a geriatric patient, but even in younger patients, because it's middle-aged patients that, young adult patients that might exhibit Addison's. Have in mind the atypical form as well, because a lot of these patients are referred for endoscopy and they are just Addisonians, so they don't need to be scoped. Hypertension and ischemia, as we said, neurologic diseases, acute neurologic diseases, traumas from foreign bodies, exercise-induced, as I told you before, for the working dogs, and also the toxins. Please always have in mind zinc toxicosis, because zinc toxicosis causes hemolysis. And where could we have zinc toxicosis? From old coins that have zinc, for example, I have experienced neoplastic lesions, and also gastrine hypersecretion tumors like mast cell tumors or gastrinoma. Always differentiate from the hemorrhagic enteritis syndrome from the acute hemorrhagic enteritis syndrome. The Clostridium enterotoxicosis, it has totally different clinical features. And always do a coagulation profile assessment. Why? We always want to measure PT-PTT and check the liver function, because this is when the liver function is not well, then we might have problems in the coagulation profiles and consequent ulceration. Let's have a look at this Sharpe hematology results. So for a reason that we were very surprised, each and every one of us, the HCT was low, but it was not that low that, as we had in mind when we did the clinical examination. Maybe it was also vasoconstriction due to pain that caused more the pale mucous membranes, because this was not in relevance with the 32.27 of the HCT that we saw in our CBC. The platelet counts were low, but they were not actually low because we did a slide, a smear, a blood smear, and we had a lot of clots as well. So to sum up, we had a mild anemia and a lymphopenia, and not a true thrombocytopenia. I'm not going to go into recapping the whole anemia thing, but I really want you to take a good look on the blood loss and what kind of anemia it could end up to. So we have regenerative and non-regenerative responses. If you have acute blood loss, then up to 3 to 5 days, then you're going to see non-regenerative anemia and maybe hypoalbuminemia or total protein counts that are lower. If you have blood loss more than 7 days, if it's a chronic blood loss, then this is where you're going to have regenerative, a more strong regenerative response and hypoalbuminemia. And in chronic blood loss, if you have very small amounts of chronic blood loss, this happens a lot in humans as well, when they don't have, black feces, this tarry feces appearance, you're going to have iron deficiency anemia, microcytic and hypochromic anemia. So beware of all these changes. It's not black and white. And also we have to always keep in mind the pre-regenerative response to wait for it. So a lot of people say, oh, no, it's not blood loss because I'm past, 3 days and there's no regenerative response. It's between 3 and 5 days that you could have, the regenerative, even past a week that you might have the regenerative response. So do not differentiate anemia on this basis. So the chronic gastrointestinal hemorrhage, and I highlight that the chronic gastrointestinal, not the acute one, will have microcytic hypochromic anemia most of the times, thrombocytosis, and low ferritin and low ferrum binding capacity. The biochemistry was normal. Everything was pretty normal in this dog, and never expected what we would see in the endoscopy, and I will show you what we saw. So hyponatremia, it's not typical of gastric hemorrhage. Gastric hemorrhage, most of the times, they have like high BUN levels and low and normal creatinine levels. There are other signs, that will make us understand. Sometimes we have increased ALT when the anemia, of course, is very profound because we have liver, the liver is not oxygenated very well due to liver hypoxia. So our lipase also, the DGGR was normal, and always perform DGGR lipase is very sensitive, it's highly sensitive. And the baseline cortisol, of course, was normal, but we had to perform it in order to exclude everything. And as you see, all the rest of the biochemicals are fine. What would you do with these? I'm going to show you the urinalysis, and put some answers in the chat box so that we can a bit, maybe talk about it. The specific gravity was 1,016. It was kind of low. And if the cholesterol levels were also low, then this would raise some suspicions of atypical Addison's. But of course, the baseline cortisol was far out of the range of the suspicious, the gray zone. So we didn't proceed with an ACTH. We had inactive sentiment and no proteinuria. Any ideas popping up? Let me see. Otherwise, I will go. Greetings to Shanghai too. Okay, let's see what this animal had. Let's start a conversation. This was a case that I saw, not even 1 month ago, 2 months ago. When was it? Okay, I'm going to give you more hints. Imaging, mild splenomegaly, a mural thickening of the stomach with loss of the normal wall ecotexture. That was a big finding in our ultrasound, and gastric hypomotility. And let's see the esophagus. Mind you that the animal has been vomiting for no, it didn't have polyuria and polydipsia. No polyuria, polydipsia. Polydipsia may be caused by gastritis during a profound gastritis, but this dog did not exhibit any polyuria, polydipsia. This is at least what the owners said. And it wasn't on any urinary diet that might also dilute the urine. But from the from the specific gravity, it seems that it drank more water. So you see that sometimes the owners will not say anything about polyuria polytipsia, but the animal might drink more water than it should. Okay, let's go to the esophagus. As you see, we have an esophageal hypomotility. We have esophagitis, definitely, and it's stage 3. I will show you how we stage the esophagitis. You see a lot of circumferential erosions, and they're up to the base of the heart and even further up, which means that the animal had gastroesophageal reflux disease due to the chronic vomiting, and the reflux disease has affected the whole lumen of the esophagus. Okay, and of course, profound esophagitis, a lot of lesions proximal to the cardia, as you may see here. And we have the HB on, the HB, the hemoglobin enhancement, and we have a lot of gastric stasis content. The gastric content is there, just floating in the stomach, which means that it doesn't proceed easily, like the mechanical or the functional outflow obstructions that we have in the pylorus. But let's have a look a bit in these lesions. And as you may see, I have my hemoglobin enhancement on. This is a novelty of Aohua, actually, that you can see better all the lesions all the ulcerated lesions, both in the esophagus and the stomach, and take advantage of this button. Don't leave it on throughout your endoscopy because it will alter your perception of lesions. But please do your endoscopy with and without the hemoglobin enhancement on button, so that you can have a better perception of where the lesions are. And in terms of classification of the esophagitis, this is extrapolated. This is an extrapolarization from the human reference, from the human book references. It's the Los Angeles. There are a lot of other indexes as well. The Los Angeles, the Savoy-Miller. I tend to use the Savoy-Miller because it's more descriptive. So if you have just one lesion, one erosion, it's grade 1. If you have several erosions in more places, it's 2. If you have a circumference of lesions, it's 3. And of course, Barrett's esophagus in humans, which is grade 5, has been proven in some cats nowadays, the gastric metaplasia of the esophagus, but we won't talk about that now. Okay, and let's see what we had in the stomach. This is the J maneuver. So we actually sucked all the gastric content so that we can have a better vision of the mucosa. And as you can see, the stomach is full of digested blood. So we expected that we have some kind of a hemorrhage, either duodenal or gastric, because sometimes it reflexes back the duodenal ulceration material. So we have digested blood everywhere. And now we are in the J maneuver where we're seeing our scope and the cardia, but we cannot see any ulcers. We're just seeing the digested blood on the mucosa. And if you're not sure, flush the mucosa, flush it in order to wash the mucosa and to see where the true ulcerations are. Where is it bleeding for? Is it bleeding anywhere in the fundus of the stomach right now? And wait, be patient so that the stomach opens so that you can have a broader visualization of your area. Otherwise, you might lose the lesions or some ulcers. So I'm just waiting here for the fundus to open up. And if you can't open up, if you can't infuse air, then you can also grab the trachea of the animal so that the fundus opens up. So here it was just, gastric hypomotility, retention of significant gastric fluid and digested blood, and nothing else, but no ulcers in this area. Let's go a bit further down. As you may see before starting the video, this is now the incisura angularis, and this is the antrum here. You see this massive, massive ulceration, very deep crater with a huge crater, okay? And this was on the 11th of May, actually. It's a very recent case that we had. So you see in the necrotic center, the crater in the incisura angularis, thickening of the mucosa. These ulcers, the periphery of these ulcers tend to be very, very thick. And as you can see here, the mucosa is infiltrated by neoplastic cells, because it's highly probable that this is a neoplastic tissue. Here as well, this is not normal tissue, and this works as a blockage. Why did we see that the stomach was distended and that we had such a huge amount of gastric content in the stomach? Because this ulceration and proliferation of tissue actually works as a blockage to the pylorus. So it's a mechanical obstruction. And of course, the antrum revealed this ulcer. When we went into the antrum, it revealed this thickening of the mucosa and the ulceration. But the pylorus was easily accessible. And we took samples, of course, from the periphery of the ulcer and not from the necrotic tissue. Otherwise, you might have a false diagnosis. So what we do is that we proceed our forceps. We take the air out so that all the tissue comes into our forceps, and you try to be vertically, because these lesions are very hard and very slippery. It's very easy to slip away from the lesion. And then you see if it's bleeding. So if you took, of course, the whole stomach is bleeding, but if you caused some bleeding so that your sample is representative. Okay. And just for the record, this is the small intestines endoscopy, which was normal, mildly increased friability. It was not nothing extravagant to macroscopically at least, and microscopically just saw a mild lymphoplasmacytic infiltration. And this is just for the record. You saw a huge lesion in the stomach. Do I proceed to the small intestine? Is there a need? Why should I go into the small intestine? Do you think that there was a need for me to go in the small intestine? The best part to take the samples in this case would be in the periphery of the ulcer, and also to the proliferative tissue that we saw in the antrum. I'm taking the samples that I'm taking, both from the stomach and the intestine, are between 8 and 12. 8 to 12. Is there any clinical usage into taking samples from the other parts of the stomach as well? Definitely. You will always take samples from each part of the stomach and from the intestine. Because what if there was another ulceration, for example, in the duodenum, and I would lose it if I wouldn't go in, okay, or any other underlying pathology? You do not diagnose macroscopically, you only diagnose microscopically. So the histopathology results for the small intestine, we had a mild to moderate chronic lymphocytic, so it was mixed infiltration. For the stomach, it was, of course, an adenocarcinoma, a very nasty one. And one would think that this dog had 32 of an HCT with such a huge ulceration. This was really, her coping mechanisms were really, really good. Just a few words, we're not going to go into that. Gastric adenocarcinomas most typically develop in geriatric patients. The length of the clinical signs prior to the diagnosis, and this is the difficult part with the adenocarcinomas, that we only see them at the late stages, that we cannot do a lot of things. So it ranges from 2 weeks to 18 months. This dog was actually admitted 1 month after severe clinical manifestation of the disease. And it's high, it has a very high metastatic potential. The only thing that we can do is surgery if it's not diffuse in the antrum. I will show you the techniques. In this animal, unfortunately, we cannot do anything but complete gastrectomy, which the owners refused. So there are these, so we only gave palliative treatment. We restored the fluids and electrolytes to restore the gastric mucosal barrier with sucralfate and omeprazole. And I will comment on that. Do we need to give sucralfate plus omeprazole, both of these medications? We will comment on that. I will show you the recent consensus on the treatment of gastric ulcerations. So it was the Bilroth 1 and Bilroth 2. Let me see, because we have another question. Normally around the ulcer, never in the middle of the ulcer. The question was, where do we take the biopsies? Around the ulcer or in the middle of the ulcer? Around the ulcer, in the crater of the ulcer, never in the middle of the ulcer. So we have Bilroth 1 procedure, which is some remaining, and you see here that there is a remaining portion of the stomach that is anastomosed to the duodenum, proximal to the bile duct and the pancreatic duct. The Bilroth 2 procedure, different, and the Roux-en-Y method, which is, complete gastrectomy. These animals do not, the prognosis is very poor for these patients. This dog was euthanized. Actually, none of the procedures were followed. Let's go to the second one. We had this sweet, and it's all girls today. In other presentations I had, you can see how this animal is suffering, breathing with a labored breathing, eyes closed. She's not in a prayer position, but it's very obvious that this animal is in pain. So this was a Yorkie, 6 years old, female neutered, fully vaccinated, dewormed, never exposed to any toxic agents, always on the couch, always on the arms, not on the couch, always on the arms of the pet parent. So this is not an animal that would unsupervised consume anything. So the primary complaint of the owner was that during the last 4 days, the animal had hematemesis. The patient had hematemesis and melena. Developed very quickly depression, anorexia, and you know how these patients, these small breed patients are. With the first 2 or 3 vomitings, they refuse to eat. They are like, like this one, in a corner, not moving, reluctant to move, reluctant to do anything. So we had vomiting of gastric fluids during the last 10 days, and the clinical history says that 20 days prior admittance, it has been given 1 single dosage of meloxicam, 1 per day for 1 week, for the management of lameness in the rear hind limb, which was probably a patella problem. So once per day, not even twice per day. Was it under any gastroprotectant while taking meloxicam? No, but we will talk about gastroprotectants. What kind of gastroprotectants would you give, or do you normally give when you give non-steroidals? Please write to the chat box so that I can see, and we can have a big discussion about that. I know that a lot of people give cimetidine, ranitidine, omeprazole prior to the administration of the non-steroidals. Let's see what you give to protect. Side attack. Kyriako, you are my kind of person. You must have heard one of my lectures. You already knew. Yes, misoprostol is the only protective agent, though you will see in the consensus that that might not be the case also. But yes, if you want to give something, neither the pantoprazole, esomeprazole, the PPI inhibitors, nor the H2 antagonist will protect. They will only heal after the ulcer is already developed, but they will not protect. We're going to talk about that later. Okay, let's see how this case went. I really feel sorry. This was the actual pictures that the owners sent me, and I was questioning how much, give me the gastrodine, give me the drastic agent, because in different countries there are different circulations, because I can't look it up now. Give me the drastic omeprazole. Okay. Give me the gastric agent. What is good? In uremic gastritis, actually in uremia and in, okay, the question is, what is a good non-steroidal in uremic gastritis? If I can understand the question, you don't give, for analgesia, you never give non-steroidals if you have chronic kidney failure. Never give non-steroidals because it will elevate the creatinine, because the renal blood flow is suppressed, so you might have other problems as well. Okay, so these are the actual photographs from what this dog, Melina and hematemesis, pale mucous membranes, depression, of course, hypersalivation, fever. She also had fever. What are the most common lab abnormalities in dogs and cats with GI ulcerations? Signs of iron deficiency, like microcytosis and hypochromatia, and hypoproteinemia, and elevated urea with a normal creatinine level, and anemia, which varies, could be regenerative or non-regenerative, depending on, yes, famotidine. Okay, famotidine, we will talk about it later. It's not the correct agent to give before as a prevention measure for gastric ulceration when you give non-steroidals. Let's say, for example, that a dog comes with an orthopedic problem and you want to give long-term non-steroidals. You will not use neither PPI inhibitors nor famotidine. I will give you the literature and what you should do. And I'm saying that to all the orthopedics out there. Okay, very low HCT level, 18%, neutrophilic leukocytosis. The absolute reticulocyte count was not, that profound. It was 78,000. It was not that high. Always use the corrected reticulocytes count, and this is the correct way of calculating it. And if the CRC is more than 2.5, then you have regenerative anemia. And always bear in mind that it might take 4 to 7 days to have a regenerative response. Okay, so sulfate. I love that you keep on going with the medications. I love all these medications, and I will tell you later on what to do. So, hemolysis versus hemorrhage. What do we have? Of course, now we know that we gave non-steroidals, so we are very suspicious, that this could be hemorrhage. in general, so that you have, that we all have a reminder and a recap. When you have a hemorrhage, you could have normal or low total solids. In hemolysis, you mostly have normal total proteins. In hemorrhage, you don't have icters, jaundice. In hemolysis, most often you do. Hemoglobinemia, no in hemorrhage and in hemolysis. You can have this table. I will give you this table so that you can, and I'm certain that you can find it in a lot of textbooks. Okay, let's have a look at the biochemistry profile of Millie, the poor Millie. And it was one of my son's classmates, the owner of this dog. And you know how stressful it is when it is from people that you have in your family. Anyway, that's another story, the story of our lives as vets. The BUN elevated the creatinine normal. So this rings bells that this could be gastric hemorrhage. Why is this? As a pre-renal increase. Okay. The total solids low. Albumins, hypoalbuminemia, and hypoglobulinemia. And I only can pronounce these words because I'm Greek, and these are Greek words. Otherwise, I wouldn't expect anyone to be able to pronounce these words. So anyway, albumins 1.9 and globulins 2.9, hypoproteinemia, severe hypoproteinemia. Total calcium low. Okay, I want to highlight something here. Is the total calcium really low, or is the total calcium, do we have to do something else to reveal what the total calcium concentration is? I will show you. The cholesterol was elevated. ALT and AST, they had a moderate increase, which was due to liver hypoxia. The rest, normal, baseline cortisol normal, the ionized calcium normal, and of course, due to the chronicity of the vomitings, we had hypokalemia, hyponatremia, and hypochloremia, which is the normal pattern of chronic vomiting patients. Whenever you have hypoalbuminemic patient, please correct the calcium. The calcium is not low, and this is the algorithm to correct the calcium. It's very easy. You just have you put your measured calcium minus your albumins that you measured plus a 3.5. There's another one that's more perplexed, but I tend to use that. In your case, there is, they have extremely, especially this breed has extremely low calcium when they are hypoalbuminemic due to the low magnesium as well. I always tend to measure magnesium in these patients, in my hypoalbuminemic patients. So please beware of correcting, and this is the mechanism that I write there. Please correct the calcium and don't add calcium in your fluids. Okay. So what did we say that we're going to do? We are going to create a problem list. And the problem list, of course, is hematemesis and melena. And the profound problem here is the investigation of hypoalbuminemia. Why is the dog hypoalbuminemic? Could this dog have a liver problem? And due to the liver problem, the patient does not synthesize albumins and also has ulcers in the stomach, or a coagulation, a more systemic coagulation problem, or could it be due to gastric ulceration because we had in our clinical history the non-steroidal? So this is how we should think. And when we approach hypoalbuminemia, there are three things that we have to always remember: reduced production, increased consumption, or increased loss. There's no other, way. So you either have a protein-losing enteropathy, you either have a protein-losing nephropathy, or they're not synthesized in the liver, or you have an increased loss due to hemorrhage, for example. Or burns, extensive burns also could cause hypoalbuminemia. So we have to investigate every parameter to exclude any extraintestinal disease, even if we're pretty sure that we're going to find gastric ulceration. We have to. Liver disease, pre and post bile acids, the dynamic bile acids test and PT-PTT were normal. Urinalysis, you see the specific gravity, inactive sediment. The UPC was 0.4, so no protein-losing nephropathy, excluded. Acute pancreatitis as well, CPLI normal. The baseline cortisol, as I've shown you previously, normal, so no Addison's disease as well. The abdominal ultrasound, all the internal organs were normal, and an increased stomach peristalsis. This is only what we saw. So with all of those things, we have excluded all the extra intestinal disease, and now we're ready to proceed to our endoscopic procedure. Never proceed to any endoscopic procedure if you haven't done your preliminary workup, okay? And the stomach, as you will see, had multiple dotted ulcers at the pyloric region, and the small intestine, no macroscopic lesions. And this was the gastroscopy. You might see that we have ulcers in the antrum. This is the pylorus here. So we had lesions in the antrum in different stages that were hemorrhaging. Okay. And no duodenal ulceration, just in the stomach and just in the pyloric, in the antral region, actually. Okay. What did we do to Millie? Blood transfusion, because this way you can get both albumins and A2 macroglobulins, and the hematocrit is low. If the hematocrit is not low and you have a hypoalbuminemic patient due to chronic enteropathy, for example, due to lymphangiectasia or due to lymphoma, when you have protein-losing enteropathy, then you can give human recombinant albumins with a certain protocol that I will give to everyone who's interested. Okay, and of course, restoration of electrolyte disturbances. This is the rescue treatment. Let's see a bit about the consensus, because a lot of things have changed during the last 5 years in gastroenterology. I know that a lot of you use cimetidine and famotidine and ranitidine, but it has been proven that PPI inhibitors are the best ones to actually heal the duodenal ulcerations and also for gastritis. Let's go to the differences between the dogs and the humans. The pH is totally different in dogs. So the intragastric pH of healthy dogs is really low, if you see, in 2 studies that was. So the consensus of antacids, first of all, there are insufficient evidence that the antacids, and when I'm talking about antacids, I'm talking about the aluminium malox, the aludrox, all of these aluminium components that, or magnesium components that could be used as antacids. So these agents should be administered every 8 hours. So they have to be administered very frequently, and it hasn't been proven that they can actually heal the ulceration. I know that your observations are different, that you think that they might heal the ulcer or that they might have an effective result, but the evidence-based medicine show that they can't. So I'm going to show you the H2. The H2, I have stopped using them more than 5 years now, because it has been proven that, first of all, they cannot, dogs and cats tend to have something like a compromise during the first 24 hours when you give, for example, cimetidine or ranitidine. After the first 24 or 48 hours, they don't work anymore. There's a lack of benefit for administration. Monotherapy given twice daily is inferior to PPI treatment given twice daily. And that's a fact nowadays. So PPIs are the most effective drug, which is esomeprazole, pantoprazole. I can give you the dosages if you need them as well. All PPIs, for example, are at the dosage of 1 milligram per kilo, twice per day, not as in humans. In humans, it's once per day, but in animals, it's twice per day. They should be given shortly before a meal, 30 to 45 minutes, or with a meal, preferably before the meal. And if you give omeprazole plus ranitidine, famotidine, or anything else, then this compromises the actually action of omeprazole, so don't give it. What are the the adverse effects of PPIs? They can cause intestinal dysbiosis and diarrhea if they're given prolonged. And in our minds, we only have cortisone to taper the dosage. No, please get in your mind that there are some medications that need tapering as well, like PPI inhibitors. We tend to cut them off abruptly, but they have to be perceived as medications that need tapering. Okay. It actually, if you saw in the previous one, the PPI inhibitors in extreme cases of very long-term use, they cannot cause atrophic or hypertrophic gastritis, but what they can cause is for the animals to be prone to ulceration if you give it along with non-steroidals sometimes, which is a bit, weird. Now, misoprostol that we were talking. Misoprostol, if you go to your pharmacologic formularies, misoprostol in humans is the only drug, the only medication that can act prophylactically and as a treatment. It's the only medication that can actually prevent ulceration from non-steroidals. And we're talking about non-steroidals here, not other medications. Okay. So in animals, the only survey that has been done, the only research that has been done was to high dose aspirin, and it has prevented gastric ulceration from high dosage of aspirin. It hasn't been tried for other non-steroidals, so we don't know what happens with steroidals, but we perceive that this might follow the human pattern. So you orthopedics out there, if you want to give non-steroidals, especially long-term steroidals or high dosages of steroidals, please use misoprostol instead of using any other medication that does nothing as a protective agent. Okay. And of course, there is no evidence that it decreases the gastric ulceration from glucocorticosteroids. Let's see about sulcrafate now. Is there any evidence that we should give PPI inhibitors or H2 antagonists with sulcrafate? There's no evidence to support. So what they say is that if you want to go on to treatment, you can give only PPIs without sulcrafate, and the result will be the same. I tend to use sulcrafate plus PPIs with a half an hour of an intermediate gap, but the evidence show that proton pump inhibitors are superior to sulcrafate for the management, and that we don't need to use them in combination. I'm only giving you the facts, and we have to comply with the facts. And also, low-fat diet. This is a key component. There are a lot of companies that have clinical diets that are low in fat. So please use low-fat diets because they promote the motility. They can be easily be accessed from the stomach into the intestine. And of course, the soonest possible, the soonest you stop, you cease the vomiting episodes, give in canned form. And in the beginning, it should be more of a liquid form, just to promote digestion. So what did we do? Do we give antimicrobials only if the animal has fever? because we're very or is septic or has very low neutrophil count. These are the antibiotics that you might use. Antiemetics, of course, and I tend to use maropitant because I love the analgesic effect that it has, the abdominal analgesic effect that maropitant has. Antacids and H2 antagonists, we already talked about it. Proton pump inhibitors as a treatment are the best option, even over sulcrafate, and even over a combination of sulcrafate with PPI inhibitors. Misoprostol is the only gastroprotective agent that can be used both prophylactically and therapeutically. Of course, you always have to be aware if the animal is pregnant or not. And if you want to do analgesia, fentanyl or tramadol are a good option as well, if you don't have opioids. There's another gastric protective agent nowadays that's been under, a survey. We don't know yet the results of that. We need more thorough research on that. So the zinc carnosine, it's not like a medication, it's like a supplement. So we're waiting for more information on zinc carnosine to see how much it will help in the animal sector as well as a gastric protective agent. And let's go to the third and final. I don't know if I have time. Please text me if I have time for a third clinical case, and we're off. So Molly, 10 years old, female, neutered. Let's watch her. Molly never vomited, never. She only did this thing here. And this is a video from the owner. You see that she's doing lip licking, which is actually nausea. What else could be lip licking? Lip licking could be a form of a focal epileptic seizure, but this dog actually had nausea because it had a lot of drooling and a lot of hypersalivation, but no vomiting, not even once. She didn't vomit at all. Loss of appetite, no history of drug administration in the recent clinical history, no exposure to any toxic agents or to rodenticides, in order to have a rodenticide toxicity, no recent vaccination, nothing. No one in the family was operated, because sometimes when someone in the family is operated and they take non-steroidals, the animals tend to steal the non-steroidals. So always ask if an animal comes with gastric hemorrhage or ulceration. I always do. Is anyone in the family operated recently? Okay. So you see what she's doing. And this is out in her walk. Look how she is collapsing. She cannot even walk. And look what she's doing. She is helpless. She has no more strength. She's reluctant to move. Oh, the poor girl. And this is what she defecated without not even one vomit. Okay. So when we examined her, she had pale mucous membranes, cranial abdominal pain, weakness, of course, as you saw, and tachycardia. Microcytic hypochromic anemia, eosinophilia, neutrophilia, thrombocytosis, all the characteristics of chronic gastric hemorrhage without the owners having perceived anything. Low total proteins, the total bilirubin was normal, mild hypokalemia, PT-PTT normal, a mild increase in the liver enzymes due to the hypoxia, liver hypoxia again. I want you to pay really attention to these two, the DGR lipase and the CPLI and the fibrinogen. These were normal, and I'm going to tell you later why I'm highlighting these three. So we have DGR lipase normal, CPLI normal, okay. And increased BUN, creatinine normal, indicative of gastric hemorrhage. The urinalysis and the rest of the serology, hyperstenuria, the dog was dehydrated. actually, and proteinuria +1. Do we evaluate +1 proteinuria when we have such a high specific gravity? Do we? No, we don't. If we have 1,055 of a specific gravity with no for no other reason, we do not assess proteinuria. Okay, we think that it's normal. ACTH stimulation test, normal. Thyroid, normal. And of course, in Greece, we have Ehrlichia and Leishmania. We always test these diseases, negative. What would you do? What would you do with this case? Let's see the gastroscopy. So we went for a gastroscopy since we excluded all the extra-intestinal diseases, and you can see that we have diffuse ulcerated areas, and the animal is actually eating foreign materials as well. It's exhibiting pica, you see, because it wants to alleviate the discomfort, the abdominal discomfort. So you see these extensive ulcers, and these are in the body of the stomach. Okay. This dog had gastrinoma, Zolliger-Ellison. How can we diagnose gastrinoma? And it's a pancreatic tumor, an endocrine pancreatic tumor. This is why I told you that the CPLI was normal. The GGR lipase is normal. How could this dog have a problem in the pancreas? In humans, yes, it's recorded. In humans, CPLI are very, is elevated when they have gastrinoma. In dogs, it's not. So you're not going to have a hint from that. Okay. The differential causes for high gastric concentrations is chronic renal failure, when we have gastric outlet obstruction, in small intestinal resection, in the enteropathy of Basenji dogs, in gastric dilation and volvulus, and sometimes in administration of proton pump inhibitors. This is why we have to cut off every proton pump inhibitor or antacids before we measure gastrin. But in order to be, indicative of gastrinoma, it has to be 10-fold up. Every lab has different reference values, but for every lab, it has to at least be 10-fold up in order for us to start thinking that it could be gastrinoma. And these are pictures of the same stomach with the Zolliger-Ellison. There are three situations that we have gastric hyperacidity. The first one is mastocytosis. So please, whenever a Shar-Pei, for example, or a Labrador comes in with vomiting, with chronic vomiting, check for lumps and bumps. Do a thorough clinical examination, because these dogs will probably be scoped and you will find nothing, because it could be not systemic mastocytosis, for example. Could be just skin disease. So stick a needle and do an FNA before you do endoscopy. I know that Aohua will kill me now for saying that, but please do a very thorough clinical examination. Okay. And uremia, I have to put a slash here because this is not the case anymore, as recent research shows. Okay. So how do I diagnose it? You stop antacids for at least 2 days prior to testing, and then you take the gastrin, you send off for gastric concentrations. Also, if you have increased liver or kidney parameters, we said that this could alter the results. The gastric pH in a fasting state is between 1 to 8. As we saw, it's close to 1.1 to 2. So if you have a markedly acidic pH less than 3 and high concentration of gastrin, then this is gastrinoma. In mastocytosis, you have a low concentration of gastrin, and in achlorhydria, you have high gastrin with a higher pH, okay, gastric pH. So this is the differential diagnosis. So to sum up, in gastric hemorrhage, we always have melena, always, but you might not always have hematemesis, as we had in the last case. When administering non-steroidals for prophylaxis, please give misoprostol. Beware of coins and metallic foreign bodies in order not to have zinc intoxication. Sometimes also hematemesis might originate from bronchopulmonary disease causing hemoptysis. So you always have to assess a patient that's dyspnoic, for example, as the Yorkie that we had. Of course, we had x-rays and everything in order to exclude that this could be a respiratory disease, okay? And the animal then will actually digest the blood from the respiratory tract, and you will also have melena, but this will not be GI disease. And for those of you who will use Pepto-Bismol or activated charcoal in toxicities, please, this makes the stools look dark. So don't be confused by that. Thank you very much. I chose today to take a case-based approach so that we can, have a discussion. If you have any more questions, the session will be recorded, but it will not be uploaded yet in YouTube. So only maybe for those of you who attended it, we will be able to send it, and it will be later on when we finish this series of webinars. We will see about that. If you have any questions, I'm more than happy to answer. Yes. And for my colleague who actually gave famotidine, please beware when you give IV in cats, could cause hemolysis as well. Beware of the famotidine.
Yes, please feel free to ask any questions to Dr. Vasilicki.
Or if you have any similar cases, and you want to discuss them.
So, okay, as Dr. Vasilicki mentioned, I think some of our attendees want to have the record.
Thank you very much. Thank you, everyone. Thank you too.
If you want to have the record, please send the email to us. Or you can
give my best regards to Cyprus, Zacharia. If there's no misoprostol, then the next best option is PPI inhibitors: pantoprazole, esomeprazole, lansoprazole. And if you give omeprazole, please beware that you cannot open the capsules, because if you open the capsules, then the capsules are deactivated. Okay. Thank you too very much, Makram. Thank you. Thank you for your time. Thank you. It's wonderful to see you all from all over the world. Is it possible that atypical Addisons create chronic colitis without emesis? Atypical Addisons is the great imitator. It could, it could actually give just an animal not being well with wax and waning symptoms. Yes, it could cause colitis. It could cause a lot of things. In prolonged cases, you could have also emesis as well. You should always check if you have a low cholesterol. If your baseline cortisol is below 1, then it's a piece of cake. But if it's between 1 and 3, you should always do an ACTH test. Let me check. If we can give opioids to patients that undergo manual evacuation of feces due to chronic constipation and anorexia, are NSAIDs and opioids. I don't know if you're going to have a good analgesic effects. Yes, you can go, but it's very heavy, you know, in order to give for evacuation. What we do for evacuation, though, you're talking about constipation cases. These constipation cases have actually to be sedated. And in order to manually evacuate the feces, what you can do is use your entero forceps, the forceps that we use for intestinal surgery, intestinal operations. They can remove the fecal material. And of course, good hydration. Hydration, if it's fiber responsive, if the constipation is fiber responsive, because there are constipations that are not fiber responsive, and you give a lot of fibers, and this causes huger problem to the intestine. So if it's fiber responsive, you can add the fiber content or use psyllium as well. Hi, Mihaly, thank you too. Let's see the next question. In case of intestinal ulceration, most of the times it's duodenal. So what stands for gastric ulceration also stands for duodenal ulceration. What we do is PPI inhibitors. The dosage of omeprazole is 1 milligram per kilo twice a day, not half a milligram in the morning and half at night, 1 milligram twice a day. And do not open the capsules. If you want to omeprazole, for example, which is the same dosage, and it can be administered with a small amount of food. I know about megacolon. There's also a medication that's called prucalopride, and it's I tend to use it, but the medication is only for large dogs. Cisapride is one of the best, and I know it's very hard to get. But also, what you can do, all the other prokinetics do not work. See if prucalopride, not cisapride, is in formulations that are available to you. And it only targets the large intestine, whereas cisapride can target the esophagus, the stomach, and throughout the gastrointestinal tract. Prucalopride only, and I'm going to write it down to the chat so that you can see it. Type prucalopride. Okay, this could be an alternative, but I don't know if this exists in your country. Let's see. If we open the omeprazole, then it doesn't, the omeprazole should be absorbed in the intestine. And if you open it, then you deactivate it. Unfortunately, nothing happens. This is not sufficient. IBD in cats, endoscopic biopsy is the gold standard to diagnose. If not, what's the best way? Okay, the IBD is a huge issue. You know that if if it's IBD, then the lesions are in the mucosa. So you will definitely have a diagnosis with endoscopy. But what if it's microcytic lymphoma. T-cell microcytic lymphoma, for example. How are you going to differentiate that? Then you need to do PAR, you need to do other things, and you need you need actually deeper biopsies, and full thickness biopsies there are indicated. Although, having said that, team, go to Aohua Vet, and you will see that we have uploaded a case of a cat that we diagnosed lymphoma with endoscopic biopsies. Okay, there are techniques for you to take deeper biopsies from the intestine, and this could give you, and all these new techniques like PAR and planarity can give you better results in differentiating between IBD and lymphoma. I don't know if this answers your question. And if you're trying to confirm IBD, then how do you do about biopsying? Yes, you do biopsy all the parts. You take biopsies from all the parts of the stomach and the intestine, the further down that you can do. Of course, the duodenum and the further down that you can go. No, never just the ones that look abnormal. Macroscopically, there are some parts that might look normal, but they could have infiltration. If we use steroid, do we need to give gastric yes, most of the times we do. Even in steroids, we do give misoprostol, though it has not been proven for steroids that they can cause gastric ulceration. Okay, yet you can give. Hi, wouldn't one for IBD cause gastric acid suppression? No. It will not cause gastric acid suppression. So the side effect that has been observed in humans, like hypertrophic gastropathy, has not been observed in dogs. In dogs and cats, the only actual side effect that you might have is intestinal dysbiosis. And diarrhea from chronic omeprazole, but we're talking about chronic omeprazole. Please, all the questions that I was not able to answer, I will answer through an email. Pop your emails, and I will answer whichever other question I haven't answered. Thank you very much. Oh, another one. Okay, let's go to another one. Can we use ranitidine, omeprazole, and sucralfate concurrently? You can, but as you saw in the consensus, it's not needed. You can only use omeprazole, but if you choose to use all of those concurrently, you can use sucralfate and omeprazole, and you can use it for up to 1 or 2 months. It depends on the cause of the disease, of course, the duration. And also, they have to have a half an hour gap between one another, not all together.
Okay, I think it's time. So I want to say thank you for all the questions, for all the brilliant questions, and also thank you to Dr. Vasilikhi for the perfect presentation. And you know, this is a monthly event, so we will see us together in next month. And the time, the invitation you will receive from our social media or from our distributors. So please contact us by LinkedIn or Facebook or YouTube. And some of attendees want to get the record. So please send an email to jason.feng@aohua.com for the
Jason,
record.
please type it so that people can see it, because otherwise they might make a mistake.
Okay, I'm gonna send
in the chat, maybe.
Send a message to every attendees. Send
a message so that they can have your email. Okay. And I see another question now. With pantoprazole, it's the same thing as omeprazole. It's the same thing. Loperamide, please do not use. I will comment. Grace, I just seen your question now. In terms of loperamide, for example, I do not want you to use loperamide because actually what it does is that it paralyzes. We humans use it because we have to go to our work. So we use Imodium in order not to have accidents. But what it does is that it paralyzes the motility of the intestine. And then what happens is that all the feces are dehydrated, and this is how it actually works. So it's contraindicated for people and for animals to have it more than 3 or 5 days because there could be an interception to that. And I will comment, I will send you an email about the eoskin because I know that we have to close.
Okay, so there's no other questions. If you have more questions, please contact us and contact Dr. Vasiliki, maybe by email or by social media.
Definitely. And I will comment. I owe one more answer, and whoever wants to answer anything else, I'm more than happy to answer any questions and remaining questions. Have a nice evening, morning, wherever you are in the world. And I will see you next month with another interesting topic. Thank you very much. Thank you very much, everyone.
I think next time I should put my email address on this slide, so everyone will know how to contact us. And I think if you do the registration, there will you will see my email address.
Jason, but it would be better because a lot of people have left their emails here. It would be better for this time to send an email to all attendees and then.
Yeah, next time I will put my email address on this slide. Yeah, thank you.
Great. Thank you very much. Thank you. Have a nice evening, everyone.
Yeah, thank you. Goodbye.